Hi, my name is Carrie, and I will be discussing our emergency department triage and ESI. At the end of the presentation, the participant will be able to verbalize the importance of the triage nurse role, verbalize the importance of accurately assigning an ESI level, utilize the ESI algorithm accurately, understand patient populations that are vulnerable at triage and why, identify common pitfalls at triage. Currently, I am a graduate student completing a project for my master's degree. Of paramount concern across the country and in RED is overcrowding and throughput. In order to address emergency department crowding, we must consider throughput as a whole, for both admitted patients and our treat and street patient population. Essentially, throughput begins at triage. Annually, ED nurses complete competency testing on Emergency Severity Index, or ESI for short. I assessed our department's ESI testing as a whole, which confirmed a suspicion I had about the accuracy of appropriately assigning ESI levels. This can be a struggle. Therefore, I opted to create this educational material to emphasize or re-educate on the importance of accurate triaging patients, but also to focus on areas that might be particularly challenging for triage nurses. The intention of this PowerPoint is to help provide some clarity and understanding. This is not intended to replace AHRQ's educational material or the use of the Emergency Severity Index. It is important to mention research on inter-rater reliability for the use of ESI was better with live situations than case studies. The assessment of competency was based on case studies. Interesting statistic. Between 1996 and 2006, EDs across the United States saw an increase in volume from 90.3 million visits per year to 119 million visits per year. That is a 32% increase, or an increase by nearly 20 million visits in 10 years. This increase in ED visits across the country has significantly contributed to ED crowding, which threatens every emergency department's ability to provide efficient and safe care. What is triage? Triage is the sorting of patients, which assists in determining the priority in which to see patients. The purpose of triage is to assist clinical personnel in identifying patients that could safely wait to see a provider or to receive an intervention. Triage is an important and vulnerable place in the emergency department. It is crucial to get the right resources to the right patient at the right time. It is also the beginning of streamlining the care of patients based on their needs. Every hospital emergency department has determined who should triage patients. Education and experience is an important consideration before being assigned to triage. A common theme in research is nurses should have at least a year of ED nursing experience. Some characteristics of expert triage nurses is the inclusion of observation, prioritization, objectiveness, knowledge, and flexibility into decision-making at triage. However, experience alone doesn't necessarily equate to a more accurate use of the ESI algorithm. Ideally, triage should take 2 to 5 minutes to complete. Several confounding issues contribute to triage being difficult to complete in 2 to 5 minutes, such as a high census, staffing, lack of policy, interruptions, and lack of space to care for ED patients, due to beds being occupied by boarding patients. However, a challenge EDs are encountering now are reportable quality measures such as door-to-doc time, length of stay for all ED patients, amount of patients that have left without being seen, and amount of patient elopements. All of these things contribute to the vulnerability at triage. Emergency Severity Index, or ESI, is a 5-level system of triage and used in most EDs across the country. The movement to standardize triage in the United States began in 2000. The use of the ESI is recommended by both the Emergency Nurses Association and the American College of Emergency Physicians. ESI considers patient acuity and the resources that may be needed to reach a disposition for lower acuity patients. It is used at the time of presentation to the ED only. This does not mean that the patient's condition can't change, because we all know they do. Some get better and some get worse, but the ESI done at triage does not change. ESI has been rigorously tested and determined to be both reliable and valid. According to Singer et al., the ability to sort patients, ease of use, ability to facilitate patient flow, and ability to predict resource demand were reasons facilities were satisfied with using ESI as their triage algorithm. AHRQ has funded and provided training materials for ESI. I believe as part of the orientation to RED, you had to complete this education. This was completed upon hire. Therefore, if you started here as a new grad, you may not recall the ESI material in great detail. The material in this PowerPoint was intended to help support you with some areas that might be a little challenging. To use the ESI algorithm accurately, we first need to determine if the patient meets high acuity criteria. Secondly, if the patient does not meet high acuity criteria, how many resources will be needed to reach a disposition? Decision points or questions you should ask yourself with every patient you are triaging. Does this patient need a life-saving intervention? Can this patient wait? How many resources are needed for the patient? What are the vital signs of the patient? Essentially, patients assigned to a level 1 or 2 are based on acuity, while 3 to 5 are primarily based on resources. Level 1 patients present unstable. In some studies, an immediate life-saving intervention was defined as a life-saving intervention that occurred within the first hour in the emergency department. Examples of life-saving intervention include positive pressure ventilation, including BiPAP, CPAP, BMV, and intubation. This includes the unresponsive patient that cannot protect their airway for any reason, including intoxication. Electrical therapy includes defibrillation, cardioversion, or pacing. Life-saving procedures include pericardiocentesis, chest needle decompression, or open thoracotomy. Examples of hemodynamic support include fluid resuscitation, pressors, blood if unstable, and bleeding. Examples of immediately needed medications include Narcan, adenosine, atropine, and D50. Most ESI level 1 patients are admitted to the ICU or die while they're in the ED. The level 2 patient. Ask yourself, can this patient wait? Is this patient high risk? A high-risk patient is a patient that cannot wait and their condition requires time-sensitive intervention. They may have a threat to life or limb. Examples of these are stroke patients without airway compromise, hemodynamically stable STEMI patients, septic patients, patients with non-circumferential third-degree burns, patients who have suicidal or homicidal ideation, testicular torsion, DKA, and many other threats to life or limb. A patient's medical history or age can put the patient at high risk. Is the patient confused, disoriented, or lethargic? Baseline mental status of confusion or disorientation does not warrant a level 2 designation. Is the patient in severe pain or distress? A pain level of 7 out of 10 or greater may consider an ESI designation of 2, although it is not required. 50 to 60% of level 2 patients are admitted, and they comprise approximately 30 to 40% of all ED patients. According to Sandfield, the most important factor assigning a patient to a level 2 was age, vital signs, and the need for timely intervention. Resources are only considered if the patient does not require immediate intervention and is not high risk. Once that is determined, consider the amount of resources the patient will need to reach a disposition. To do this successfully, the nurse must be familiar with standards of care for emergency department patients. It is only an estimate of the amount of resources that are needed. Unfortunately, this is not influenced by nursing workload. A bed for an exam, such as a pelvic or abdominal exam, is not considered a resource. These assessments are part of the H&P. Lab tests are considered one resource and are not dependent on the amount of labs ordered. For example, in order for urine, CBC and CMP is one resource. However, point of care testing is not considered a resource. Radiology tests are a little bit more complicated. X-rays are one resource no matter how many are ordered. CT is one resource as well. For example, there is an order for chest X-ray, a KUB X-ray, and a CT of the abdomen. This is 2 resources. The x-rays are 1 resource, and the CT is another. A level 3 patient will require 2 or more resources. There is no need to count every resource this patient will need, as the amount of resources needed does not increase the acuity. Once you reach 2 resources, there is no need to count any further. Level 3 patients typically constitute 30 to 40% of all ED visits. Some examples of level 3 patients include abdominal pain and patients that present with chest pain that does not meet level 1 or level 2 criteria. Vital signs and pain assessment at triage. The ESI research team recommends a full set of vital signs at triage, with the exception of patients who meet high acuity and need to be seen immediately. Vital signs for level 3 patients are absolutely needed every time. It is possible to have a well-appearing patient with unstable vital signs. These patients may not be initially seen as meeting ESI level 1 criteria until vital signs are taken. For an example, an elderly patient who states they are dizzy and vital signs show a heart rate of 30. This is an ESI level 1 for the need of immediate intervention, such as life-saving medications or electrical therapy. Another example could be a 38-year-old female who states her heart is racing. Upon vital signs, her heart rate is 187. They are both hemodynamically unstable, warranting ESI level 1 designation. Subjective pain assessment of greater than 7 could increase acuity, but if the patient is in no distress, there is no reason to up-triage the patient to a more urgent level. However, it is up to the discretion of the triage nurse to assign a patient a level 2 if the patient is in severe pain and is in distress. There are nursing interventions that can take place at triage to help manage pain. An example is ice for a sprained ankle. However, there is no nursing intervention for severe pain for cancer patients, kidney stones, or a sickle cell crisis that can take place in triage. These patients should be designated a level 2. Level 4 patients will utilize 1 resource. Level 5 patients require no ED resources. Some examples include a patient with a non-infectious, non-allergic rash, an earache or ear infection, medication refills. Keep in mind, point-of-care testing is not considered a resource. Elderly patients are at a greater risk for under-triage. Elderly patients often present with atypical signs and symptoms of typical diseases, which might mask a high-risk situation or even the need of a life-saving intervention. Unfortunately, their vital signs are often misinterpreted. Pediatric patients are more likely to be mistriaged than adults. It may be more helpful to use the pediatric assessment triangle initially at triage for pediatric patients to determine the need for life-saving intervention than the more common method of using airway breathing circulation. The pediatric assessment triangle refers to appearance, work of breathing, and circulation. The presence of a fever in a pediatric patient is an important assessment tool at triage. For all pediatric patients, it is also important to ask the parent of a child 3 months to 36 months if they have received immunizations. Adults and children that present with SI or HI should be classified as level 2. Pediatric patients that present confused, disoriented, delusional, or hallucinating should be an ESI of 2. These can be related to mental health issues, neurological in nature, or substance abuse related. Trauma, any patient with a high-risk mechanism of injury should be classified as level 2, unless they require life-saving intervention. Ask the question. Don't be shy. According to Garbez et al., there's a huge amount of information available for each patient at the time of triage. Less experienced triage nurses struggle to determine which information is truly relevant when assessing if a high-risk situation exists. Generally, acute onset of pain is often more concerning than gradual onset of pain. Ask yourself, what is the worst-case scenario for this patient at presentation? Can they wait? Are they at risk for deteriorating if they wait? The ability to group symptoms can greatly enhance the ability to accurately assign an ESI level. Under-triaging and over-triaging are both problematic. Under-triaging translates to delaying care to the patient, and over-triage translates to providing valuable resources to one patient at the cost of another. It is imperative that patients be assessed appropriately and assigned an appropriate ESI level so they can receive safe and timely care, which can result in shorter wait times as well as time to treatment, but also reduce patient morbidity and mortality. Research shows under-triaging patients has been reported to occur around 14% of the time. Triage nurses may under-triage patients when the department is severely crowded and there is no place to safely put the higher acuity patients. So out of fear of the patient waiting in waiting rooms, they under-triage. It has also been mentioned in the literature that accurate ESI level helps facilitate timely treatment and improved patient throughput, but in and of itself does not guarantee a better outcome for the patient. Unfortunately, inadvertent delays occur. Delays in patient care often begin at triage. Research has shown patients admitted to the ICU experience a significant delay when assigned a higher ESI level. Walk-in patients are at a greater risk for delays than our patients who arrive via EMS, although triage, by definition, is a process and not a place. The amount of resources needed to reach a disposition is not provider dependent. Pain is the most common reason to seek out emergency help. It is important to consider the patient's subjective level of pain in conjunction with the objective assessment of pain. Intuition is an important asset in triage. However, it should be used in conjunction with the patient's physiological clues to their presenting condition. This concludes my presentation, and here's a list of references. Please complete the evaluation form, and I will gladly give you a Starbucks gift card for your help. Thank you, and I hope you found this helpful.